I am the third president of the I am the third president of the College of Palliative Medicine of Sri Lanka. During this uh, very short 3-year period, we have made very good progress. Actually, we have conducted several activities across the country, and also we have achieved several significant achievements. We have started international journal for the palliative care, as well as we have conducted several capacity building program for doctors and other staff, nursing officers and other staff, as well as we have conducted several awareness program. And also we have made developed several publications relevant to the uh, palliative medicine. In addition to that, we have conducted several online courses, as well as we are every year we are every month we are conducting monthly seminar on palliative medicine, which is free for anyone. Anyone can join this monthly seminar. It will update uh, through social media, as well as the college membership. We have more than 200 the members in our membership. Yeah, then this is the college is the only professional body in which the council and the membership over 200 medical doctors and specialists. Any the medical doctors, as well as the all the different specialties are in our group. So then that really showcases the importance of multidisciplinary teamwork for the provision and advancement of palliative services in the country. And Ministry of Health has recognized us as a very important palliative the College of Pallative Medicine of Sri Lanka has recognized as a very important professional body, and also that we have developed several publications with the collaboration of the Ministry of Health. During this very short history, we have developed. So then one of the capacity building online courses for doctors as well as nurses. This is the second course that we are doing this online course for the wound management. So then we have very eminent speakers for this course. You already got the program lineup, and it has mentioned university lecturers, consultants, as well as the palliative medicine practitioners. So then I am not going to take lot of time. Um, our immediate past presidents, Professor Samadhi Rajapaksa, and our college secretary, Dr. Ishanka Talagala, and Dr. Ranga Pereira. He is the president-elect, dean, the faculty of allied science, uh, Kotalavala Defense University are joining with us today. In addition to that, all your colleague participants are in the group today. We have given all the instruction. Dr. Tusita Kahaduwa, he is the program course coordinator for this. He is a palliative care practitioner, as well as he has specialized in palliative medicine, and also he's having experience of lot of wound care management in palliative patients as well as the other patients. So then you can get all the experience, all the knowledge, as well as you can clarify all your questions during this course. We have WhatsApp group. Those who have joined in today, sometime you may be not in the WhatsApp group, so we will add immediately. Sorry about that. And all the things we are may all the information we are sending through email and the WhatsApp group. In addition to that, Dr. Chitra Senaviratna, he is overall coordinator for this course. Any queries, you can send to him. So without taking much time, I would like to invite uh, Professor Samadhi, Dr. Ishanka. You want to say something? Hello?
Yes, I just wanted to congratulate as this is the second course for the doctors, especially for the wound care management and particularly the field of palliative medicine. It's a uh, challenging topic because most of the patients with multiple diagnoses, uh, especially with bed sores and other chronic wounds, we have to tackle. So I think now with the past year experience, this course is really a wonderful. Dr. Tusita is very expert in doing that, and our team also, including Dr. Ranga, Tushan, Dr. Kitsiri, and Dr. Hilary Fernando. Uh, then so they are expert in this field, and you all can gain a lot of good knowledge, practical knowledge, and particularly how to tackle patients with bed sores and other chronic wounds. So I congratulate and wish you all the very best to get the knowledge. And for any queries, you have a chat box, and you can raise your hand and ask your questions. So thank you so much, Madam President, for considering and conducting this year also this wonderful course. Thank you.
Thank you, Professor Samadhi Rajapaksha. Ishanka, you want to say something? Dr. Ishanka? Right. Are you there, Ishanka? Right. So then Dr. Tusita will speak to you later. Now, I would like to invite Dr. Ranga Pereira, consultant oncosurgeon, and he's the Dean, Faculty of Allied Sciences, Kothalawala Defense University. He will speak about you on burden of wounds. Over to you, Dr. Ranga Pereira.
Thank you, madam. Good evening and welcome to the second course of wound care management of the College of Pallative Medicine of Sri Lanka. I think I can share my slides. I will can everyone see this?
Yes, yes.
Okay. Yes, yes.
Okay. Right. So without any delay, we will start. I'm very happy. We have 74 participants, 73, 70, over 70 participants, but including ourselves. But I think it's much more than the last time, and I'm very happy for that. A lot of doctors are joining us to for this course. Yes. So I will give you the importance of wound care in this program. One is wounds are a common problem in palliative patients. And every palliative patient, some of them have, it may be a chronic tumor, or maybe a neurological problem, maybe dementia, or any kind of a patient who is on palliative management. Wound is a very common problem. So what is the problem with the wound is at that, the basic concept of palliative care is actually improve the quality of life of a patient who is suffering from incurable condition. Now, if someone is suffering from an incurable condition, now his lifespan is limited. So in that limited lifespan, we want to make that life, the short life, a good quality life. So wounds will make that quality of life very miserable. So one is pain. Number one is the pain. Now, when someone is having a wound, it's painful. You all know the wounds are painful, right? and there is discharge. The discharge may be blood discharge, pus discharge. Sometimes the infected pus, the smell, and all these things will deteriorate the quality of life of the patient who is having the wound. And sometimes, time to time, the wound bleeds, and that will increase the burden on the patient, causing a lot of one thing is it's make the wound difficult to heal. Another thing is bleeding will make the patient anemic, and that will later cause problems for the quality of life for the patient more. And complications. Now the chronic wounds, if they are infected, they can cause sepsis. And sometimes these wounds can fistulate into internal structures, make sinuses, chronic osteomyelitis. All these things will complicate the problem from a simple wound to a big wound. And ultimately, the wound may be the cause of death. Now, the patient may be having a chronic tumor, neurological condition, or dementia kind of a disease, but ultimately, the cause of death is a painful wound causing sepsis or bleeding. That would be a really disastrous situation in this kind of a patient. And thirdly, the economic burden. Now, caring of a patient with palliative problem or incurable problem itself is economic burden. On top of that, if the patient is having a wound, caring for that wound is also become more economic problem because it increases the economic burden on the patient and the family and the carers because dressings, antibiotics, and nutritional supplements, all these things will cause economic problem for the family. So all these things are reason why we should know about wound care in this kind of patients. And our main goals in wound care is to facilitate hemostasis, minimize the tissue loss, and prevent the complications we discussed, and control the pain. And we improve the wound healing, promoting wound healing, and minimal scar formation. And most of all, what we are mainly aiming at is prevention of these kind of chronic wounds, and that will improve the quality of life of this patient. I think with that, I will come to a introduction. Tusita, I think you will take over from there.
Yes,
Just to give a
I think
these kind of
yeah.
things are what we are dealing with. Yeah, Tusita.
Uh, Madam President, I think have some words to say before my starting. Thank you very much, Dr. Anga. Madam, you wanted to say something, no?
No, thank you very much, Dr. Anga Perera, consultant oncosurgeon, Dean, Faculty of Medicine, Dean, Allied Science, Kotalawada Defense University. He will speak you again during the course. Thank you very much, Dr. Anga Perera. Now I will introduce Dr. Tusita Kahadua. He is a palliative care practitioner as well as he has specialized in palliative medicine, and he is the course coordinator for this course. He will explain about your especially assignment and how you have to do. In addition to that, there are some members who are in the faculty of this course. They have joined, and also that overall introduction for the program lineup and the faculty introduction of faculty members, Dr. Tusita Kahadua will do that. Over to you, Tusita, and followed by your lecture. Thank you very much.
Thank you, Madam. First of all, I must introduce our eminent group of lecturers. You just met Dr. Anga Pereira. He's senior oncosurgeon and is the dean of the Allied Health Faculty of KDU. And Dr. Kitsiri Senanayaka is a consultant general surgeon and he's in the Faculty of Medicine, I think, Anuradhapura. So he is really interested in wounds, and he is a very innovative wound practitioner as well as a good surgeon. And again, Dr. Hilary Fernando, the consultant urological surgeon, he is addressing something that many people do not talk about when we are talking about wounds and palliative wound care. It's a management of continence and stoma. So that goes into the extent of even prevention and wound adhesions and all those problems occur. And it's a very important aspect of palliative wound care. And last but not least, Dr. Tushan Gundaratna, he is an eminent figure in the wound care scenario. He's a consultant vascular surgeon attached to the Faculty of Medicine, Colombo, and he's a lecturer in wound care as well as vascular surgery. And in wound care wise, he's doing a lot, both clinically and otherwise in the doing a lot of associations as well as organizing the first ever certificate course in a university for wound care. So these are the eminent figures that you are going to meet during the course, and I hope you all will take the most out of this eminent panel. So and I thank everybody for agreeing to participate and agreeing to share their knowledge in this course. And the next thing I want to talk about is about the assignment. So the assignment format, I will upload it right now. So the assignment is mandatory. That will serve as the exit point of this certificate course, because we are certifying, we have to get it to a certain standard. So whatever you learn that will be targeted towards your assignment, you have to show whatever you learned in the assignment. So we'll be assessing the levels of understanding and all that. So I mean, that's not a don't take it as a burden. I am sure now, last time also everybody passed. This time also everybody will pass, but it's for your own benefit. Plus, I mean, we need you all to have some interest and sort of targeted learning behavior. That's why the assignment is there. So basically, you have to apply whatever is taught in this course. There will be say certain how to approach a patient, how to assess a wound, how to describe a wound. Those things, I mean, the way we say it, we would rather like to hear that in your assignment as well. So that you can compile that during these 4 weeks, and we will give you additional probably 2 weeks. Madam, can we give them additional 2 weeks or 1 week? Madam President?
We will give additional 2 weeks.
Additional
no?
Additional 2 weeks.
Right.
So at the end of the additional 2 weeks, you can finish it off. Don't wait for that additional 2 weeks. It's better to approach the lecturers and say, if you have your supervisors, your clinical supervisors also, get their help and get everybody's help, and compile a good assignment and send to us. So it basically the assignment. Wait, I'll upload the assignment format. So basically everything is in there. You just have to fill in the blanks but there's a certain way that it should be written, the sizes of the letters and all that, because ultimately we have to be able to compile all that into 2024 doctors program. So each one of the assignments should be formatted the same way. So I think you get what I mean. Is there any questions about the assignment? This is not the proper introduction to the assignment. I'm just telling you that it's there. Don't take it as a burden. You will pass, no problem. But you have to do a little bit of work. That's structured. So, you have any questions on that? I have uploaded it in the chat. We will go through this probably next week, because today our target is not this, basically to challenge whatever you know and been practicing right now. So so if there are no problems, no questions, I can shall I start the lecture then?
Yes, Tusita, you can start.
Yeah. I hope everybody can see the PowerPoint. Is it on?
Yes, we can see you.
Yeah. Thank you, madam. So and I would like everybody to give some feedback though, so that this is I mean, communication is a two-way thing. I I don't like to.
Tusita, can I disturb you?
Yeah.
Chitra want to say something.
Yeah, Chitra.
Chitra? Chitra wants
Yes,
to
madam.
know who is
Yeah.
this. Yes, you
Vichakshana.
can ask.
Yeah, who has joined from Vichakshana? Actually,
And
who's
Susil.
Susil?
We don't know their
Role
numbers.
numbers. Can you tell me if you have joined
Yes.
from?
1 second.
So we can start, we can remove them and they will contact us, no? Right, you can start.
So my number is 583.
Vikshana,
Susil.
Hari. Right, okay. Vikshana? Right, you can start. You can start to Tusita, you can start.
Yeah. So wait. So I just put up a set of questions. I need some answers. You can on your mics and just tell what you feel. These are very simple things. So, and should we use antibiotics in wound care? I mean, if you see a wound, should you give some antibiotics?
Not always.
Not always.
Good. So, are expensive dressings better?
No.
No.
Okay. Is there, can you use one advanced dressing to treat all? Like say, silver is
No.
very advanced silver
Each,
resin.
exactly. Each condition varies, right? So you can't use one dressing for everything.
So you'll be treating one of the wounds and there are no progression. What would you do? Just change into a more expensive, say, sort of better dressing?
Take a swab culture if required, if it's not healing, and then look at the other comorbidities why it's not healing, like diabetes can delay the wound healing, and other factors.
Okay. So are home dressings bad? I mean, do they have to come to a clinic?
No,
Not always, yeah.
Home dressings are not bad.
not bad.
Okay. So
If it's done in a proper way.
so if you heal one wound,
Hmm.
would there be another one somewhere else? I mean,
Yeah, in case of
it's
pressure sores, yes.
okay. So would you believe in karma in wound healing?
No.
No.
What about this
People do.
Helladeshiya sort of methods?
What does it mean? Eladesia?
Say
Some people believe that.
folklore medicine, that sort of things, yeah, and believes that if you put something into it, like
No, I don't believe.
some
No,
pulp of a tree or something like that.
no, it's going to contaminate the wound even more.
Yeah. Okay, good. So this is a pretty advanced group. So anyway, so this is a complex wound. Now it's we healing. So this is something that we are to expect in good wound care. So wanted to show you a wound. So you all know what a wound is, no? What a say a skin wound is. There are wounds in other epithelium as well, but we are talking about now here we are talking about mainly about skin wounds.
Is this
So
more like a necrotizing fasciitis like condition?
this is just a simple granulating
Just a
wound.
simple
But,
granulating wound, okay.
Yeah. So what I wanted to show was there's a discontinuation in the skin.
Right.
Basically, that's what a wound is. So what happens when you have a wound?
It heals on its own, most of the wounds, as in if it's
Yeah.
a simple wound.
It heals. What happens to most wounds? It heals. So we can scientifically explain that it heals in the secondary intention, no primary intention, no. But whatever way it heals. So how do they heal? Any idea about how they heal? I mean, you've been taught in this about this in physiology, no? So this you will learn this from Dr. Angapera. This is his lecture. I am just trying to make a point. That's all. So physiology of wound healing, you see, we are describing it in stages. It's a complex, very complex process, and there are so many things that are involved and interacting with each other in a very complex manner. Even there are now the body has evolved processes of communication. Yeah, extracellular, intracellular, then there's cell migration. There's so many things happening, and it's very complex. The molecular level complex. So that's evolution. So millions of years we have evolved, not only us, animals have evolved to heal wounds. Nobody can, I mean, basically it's a foolproof mechanism. Should be so complex and so many millions of years of evolution. And do animals go to wood clinics? No.
Yeah, wounds sometimes they're taken, yes.
Yeah, so wounds heal. We are geared to heal. So complex, we are evolved and we are geared to heal. But there are certain things that particularly come into play when because we are humans, we go into two legs and all that. But we everybody heals wounds. All animals heal wounds. We are also here to heal wounds. So what we are trying to do is basically now this is the process. This is the stages of wound healing. Say, stages of wound healing. You will learn that. I'm not going to into the depth in that because the next day's lecture, the whole day is about this. See, the start is a huge wound, and slowly it becomes basically unidentifiable scar, just a tiny scar. So that's what we are geared to. So, do you think we can do many things to alter this? Any idea? I mean, this is a molecular level thing.
I'm sorry, didn't get what you meant.
No, what I mean is, do you think now this whole complex process,
Mhm.
can we do many things I mean, can we like manage all of this
No,
and
it's a physiological thing.
get it to basically heal can we control this whole process?
We
Or
can
rather,
facilitate. We can
yeah,
facilitate healing.
yeah, we can facilitate and we can help it.
Mhm.
It's there. So what we are learning here, the whole course is about how to facilitate healing the body to heal on its all on its own. So that's the main idea, that we are not healing the wounds. We are just helping, and the patient heals the wound. It's millions of years of programming. You get what I mean? Any questions
Yes.
up to now?
No.
Because I have seen so many places that have put up boards saying they are doing wound care. And there are certain Facebook ads also coming in that we do, I will heal in 2 days or 3 days. And people are giving various video cuts and all that, saying that I went to this doctor in 2 days it healed and all that. Was can we do that?
No.
So that's the point. That's one challenge. So all that, all millions of years of evolution is with correct facilitation and help is able to do this. These are real life pictures of my patients. All these are real life pictures. I don't think there are any other than the cartoons. So from this to this. So this is not me. This is the patient. How to get the patient's body to do this is our uh, task to learn. So all those processes are in a balance. Basically, this balance brings forth healing. So if something is not healing, say in about a month or 6 weeks, it's not healing, the balance is gone. Can we say that the balance is gone? So what makes this balance into imbalance? So those are what we call barriers of healing, barriers to healing. So I'm sure everybody learned about the clinical barriers to healing. You must have memorized these things. Poor tissue perfusion, necrotic tissue, high bacterial load, infection, edema, copious exudate, maceration, skin problems, malnutrition, systemic conditions. Is there anybody who didn't memorize this during, I think, third year, no?
Third year.
So you have your clinical problems. So you know these. We don't have to teach in 1 month short course. You don't have to teach all this. So there are advanced concepts. I don't think it's those things have to be. I mean, okay, if you bring up a question, we can discuss. But time is a constraint here. So say the concept of bacterial load. Where do we call it? Where do we call it critical? So there are new concepts like critical inhibitory load. So those are it's been fine tuned now, these things. But anyway, basically this is what we learned in the med schools. So so some of you may have learned about the psychological barriers as well. Say pain, order, mood, more lack of education, inability of self-care, and all that. Those are quite obvious things. So, is anybody hearing the psychological aspect today? I'm sure everybody has heard all this. Is it new to anyone of you? Okay, so what about these things then? Have you heard about these things? Educational barriers, like traditional knowledge, ritualistic practice. My father was a traditional healer, and he did this, and about 3 wounds healed, and I am doing it to 50 wounds, and I am hoping they would heal. Ritualistic practice, like, okay, this is what I learned from so and so many years ago, and I am doing it to everybody. I am putting some gel, getting the patient down, and put in some gel. There's a person who burns the wound as well, and and then he puts some gel. So that's a ritualistic practice. He does to everybody. And since most wounds heal even if you treat them badly. So even his wounds heal. There'll be a fraction, about maybe less than 10%, where the actual problems we'll have to correct. So those will not heal with this. So inappropriate training and support. Lack of understanding of research process. That's very important. Yes. We are inundated with research. So much data, and we don't know what to make out of it. And do we know how to read papers properly? Can they cheat us? So those are the questions. Even if we get a very high quality research, very targeted, we might understand differently, and we think this is for every all the wounds. You get my point. So poor quality research. I spoke about the lack of critical appraisal skills, and evidence negative attitudes to evidence-based practice. Basically, the native healers and Ayurvedic, those people are. I don't think everybody is like that, but most of them have a sort of a negative attitude towards evidence-based practice, because some of the things can't be proven. Plus, it's very easy. So I do something and I see it healing, and I tell you also do it. It seems to be working for some time, and we all practice, and we are all happy hereafter, and we are not asking any questions, or we are not conducting any research. No questions, no problem. That right? And information overload, I spoke earlier, so inundated with research. So what about lack of consensus, so expert opinion? So we have a problem, and say even our panel, if we cannot come to a consensus about a certain wound, so then nobody knows what to do. So that's why there are international consensus reports and all that. So we have to be alert. And research findings can be inconsistent and say contradicting each other. And there's no standardization method. If there's no standardization method of the practice, so still I don't think Sri Lanka has it, but it will come eventually. And interprofessional rivalry, in the sense I am not letting someone else come and practice something different. Maybe that something different is based on good research, good evidence, but still I'm not letting those people to come in, because I came here first. This is my kingdom. So that kind of thing. And you must have seen the lack of effective clinical role models, I mean, to look up to. And health services instability, how that can be a barrier to healing of many diseases. You will have experience firsthand if you, I'm sure everybody experienced that during the 2021, 22 era. So lack of resources, again, you can go back to that era. So lack of focus on wound management, that's what we are mostly having now, but things are changing. So is there any question on this? So this is something I just wanted to open a new thinking pattern. So was this new, or I mean, have you all thought about this earlier?
Hello.
Oh, it
Yeah.
is new.
So
Yeah,
so
Dr.
just think,
Kahatu, I
yeah.
want to ask about native medicine. There is no such research on native medicine. How about that?
That is the problem. I mean, native medicine, we can have research, and we can devise research, but we've been working with them for some time, and trying to get things out. But the thing is now, native medicine, the problem is now these are secret recipes and all. So they don't want the moment that we ask that we want to prove this with research, what they say is, no, they are nothing to research, nothing to prove. It's already proven. This is I found this in some pentagram in my grandmother's this thing. So she has been somebody to somebody, and her 10,000-year-old ancestor was doing something. So those are the answers we get. But there are few things that will come into that are slowly coming to light, like say berberine from
නෑ
belly band.
දිනේශා මොල්ලිකට කියන්නේ මගේ ඔය මේල්
So that's the scenario. Anyway, let's move on. One other thing that I want to highlight is the causality again. Now see, there's a balance, and there are causes of non-healing. So now we have to identify the cause. Now we know the effect is non-healing. So now we have to identify the cause. Now we have a list of causes. So out of this, what? So that is causality. Now the effect is life, and cause is what? Greed. Maybe, I don't know. So that sort of thing. That is what I think Lord Buddha said. So that sort of scenario, we have to apply causality into wound healing. So that is one other important thing that I want to get through to you. So always think in these terms. So if you haven't identified the causality, you should either go back to the drawing board, back to basics, and redo it, or you have to, it's probably beyond you, then you have to ask for help. Because you have to know the cause. You have to have an explanation. Then only you can explain whatever you are doing. If you cannot explain what you are doing to the patient, then don't do it. Am I correct? There are any other opinions on this? Okay. Then the other thing is, a wound does not come to you, the patient does. So you have to manage the patient. You all are doctors. You are not doing dressing changes. Now we are learning here to do wound care. So wound care is caring for the patient. So patients we have to look at all the aspects: medical, psychological, social, economical, spiritual, all that. So remember, the wound is on a patient, so rather in a patient. So if you consider the medical aspect, you have to think about the comorbidities, diabetes. So any other, say, if the patient has any dermatological disease, say heart disease, that will affect the peripheral edema and all that. So likewise. So I can go into lists, but no, this is not the time. So, and you should assess the nutrition. There are any deficiencies. That sort of a thinking pattern. So psychologically, most patients are depressed and they're anxious what's going to happen and all that. So that has to be identified. So socially, we miss this mostly. If the patient has enough help, how is the patient going to travel? If you ask them to come in for say once into every other day, so that's the usual practice now. Every other day, better deal. So if you ask them to come to the hospital clinic every other day, is it practical in his social scenario?
No, it's not.
So it depends on the case. So you have to ask each and every. I mean, I'm just showing the a way to think, a pattern of thinking. So about the economy, how affordable are your management to that particular patient? Let's only talk about the medicine you use and the dressings you use and the frequency you use them and where you advise them to use it. About the travel and other expenses, how much do they spend for a clinic visit? And when the patient comes, there'll be another person, a caretaker, probably have to come. So caretaker also loses valuable work time. The patient anyway loses valuable work time. So we are taking the probably 2 people out of the workforce on that particular day. So loss of man hours. So repeated dressings for so many years, and the patient cannot afford to do a job. And is there a way to recover this patient into his normalcy while he's being treated for this particular chronic wound? It's going to take about 3 months, maybe 4 months. We don't know, depending on the case. Our plan is to heal in any case in 6 weeks, but might go on and go on. But can we recover him to his normalcy? Say, if the patient is doing a clerical job, can we put him, so get him into probably a pair of shoes, specialized shoes, so onto a wheelchair, get him to do his job. Say a person who's doing a shop, there are a way to adjust all that and getting him to his job. It's recovery. It's not rehabilitation. Rehabilitation is we make patient do what we want. Recovery is we facilitate them to do what they want right now. So that's another thinking pattern. So you can think about those things. We have a list of courses, and there are things to think about when we get a patient. So now you get a patient. Knowing all that, you have a lot of data. So, say 96-year-old male with poorly controlled diabetes has a right foot also for 3 months and treated at various places. So, how do you approach? So, what's time now? It's almost 10. So, I'm going to rush a little bit. So, how do we approach? It's basically the fundamentals of any clinical medicine scenario applies to this. You have to take a good history, depending on the case, the duration, how it started, what's the level of pain, there's fever now, there's, depending on the case, there's the claudication, no, there's shortness of breath, any other previous investigations, the clinical records, what the other wound practitioners thought, and etc. etc. Is there anything to add? I mean, this is not a complete list. I'm just highlighting certain things. Does anyone want to add anything? Okay, moving on.
Some drugs.
Yeah, with the previous clinical records, what has been taken? Say antibiotics.
Penicillin.
How long Has he been taking antibiotics? That's all.
Steroids.
Yeah, steroids, yes. Anything that will be an obstacle to heal. True. So, and of course, the social scenario, economy, and everything comes into this history. So, examination again is not a complete list. Just to point out certain things. Say blood pressure, pulse rate, uh, respiratory rate, temperature, all that is important. You add to that maybe WBC. You can go into various international tools, like score and all that. So you can score it as well uh, to see where the patient is in the sepsis gradient, or say if you are assessing the wound, you can get to the Wi-Fi gradient and all that. So there are certain tools. So targeting all that, you will learn all that. So when you are doing wound bed preparation and all that, you will learn Wi-Fi and all those things. So targeting all those, you have to do a targeted examination. And you have to identify the patient is whether the patient is septic or not. So there are signs of infection, local or systemic. And the other most important thing is, are there signs of ischemia? So if you miss that, the end of story. Because these things have happened. Not in the near future by doctors, but there are a lot of other people who put up boards and do wound care. So recently I have seen about 3 patients dying. People have seen, these people have seen consecutively about every 4th day. About 2 weeks, if you get the history, the patient has been really sick and septic. Even with the history, you can judge that they are sepsis. But they have been just reassuring and reassuring. So that's another problem of in wound care, that false reassurance. So it uh, adds up to delay and finally to proper treatment. So that was life loss. So signs of other chronic diseases and all organ failures and all that, and say CKD and all that, you can identify. So just fallow, you can correct it. So does this make any sense?
Yes.
Okay, thank you. So the investigations, as indicated, and you don't have to do investigations. It's not mandatory. You can order certain things, and say cultures. So since cultures came earlier, somebody discussed highlighted cultures. Do you have to do wound cultures in each and every chronic wound?
Not in every chronic wound.
So when would you do it?
When there are signs of infection and when it does not respond to your treatment or maybe antibiotics either, to see
Yeah,
what's colonizing it.
you will decide on antibiotics if there are signs of infection.
Yeah.
Yeah.
And if it's not responding?
Yeah, if it's not responding, can that be something else? Then if there's no infection, there's a point in doing
No, if there's no infection, yeah, there's no point in doing it.
no overt infection. I mean, the wounds are colonized.
Mhm.
So if you sober chronic wound, there will be a bug. But by forcefully treating it, you won't get anywhere. You are just wasting antibiotics and just putting out putting the bacteria into a pathway of resistance. Yeah. So investigations as and when necessary. You can even do MRI. Say the patient is septic, and you only see a sort of superficial wound, and the limb is swollen and all that. Better to go for even an MRI to identify where the pus pockets are. So those are advanced things. So basically, you don't need many investigations in wound care if the patient is not that septic or ill. So now we have to assess the wound. Now we have basically somehow we have got around with the patient. So now we have to attend the wound. So patient first, wound second. So this is again not a complete list, but we would like to see at least this in your wound assessment in the assignment. So this is important. So at least try to describe the case you are taking for the assignment in these topics. Just don't say it's a granulating wound in the foot. So where it is the place, the size, at least how many inches, say 4x2, 2x4, whatever. So what sort of shape, what's the base made of, what the color, basically pink. Now here the base is made of tendons. So those are vital structures. How is the edge? Is it advancing? Is it epithelializing? Is it healthy? Is it puffing out like a cancer? How much is the drainage? You can, when you are removing the dressing, you can have a good idea about it. And surrounding skin, whether it's macerated, is it like some eczema, any other alarming signs. So you have to describe slough. You have to develop yourself to identify slough to pus to necrosis. So I think since all are doctors, you must have learned all this in the med school and you've been practicing this. So does anybody has any problem with identifying, determining whether it's pus or slough? Necrosis is pretty obvious. Have you come across scenarios where you cannot say whether it's slough or pus? So that is one other things that you have to develop. So not all yellowish stuff is pus. Any questions? The other thing is whether there are important structures in the base, basically. Can you see anything in the wound, say a joint or tendons or blood vessel?
Containing tissues.
Yeah.
Pus mainly containing
Pus
white
is
blood
mainly,
cells. I think.
yeah, liquid, and it can be of many colors, and the color actually is an indication to what's the causative organism as well. Slough is basically dead granulation tissue, so it's just white to yellow adherent thing. So necrosis, can be wet or dry, can be known. There's some dead tissue, basically black dead tissue. can be of yellowish as well. So pus you can milk it out. Slough you cannot milk it out. No?
Yes.
So slough you can pull and see. Every 5 minutes stuff coming out.
I'm sorry. Stuff comes out every 5.
No, if you pull, there will be some fibrous
Oh,
strings.
right. Okay. Okay. Okay.
So those are the ways to identify. And you have to know the important structures in that vicinity, and you have to know anatomy for that, and you have to preserve. That's why it's important to describe what are the important structures. You can see in the wound, and you can actually describe the wound that you will expect these things underneath the wound as well. So it's a good practice. And you have to know how to identify good granulation from bad granulation. Have you seen good granulation? This fine,
Yes.
pointy, very fine pink thing.
Yeah,
Bad
they have a good
granulation.
blood supply.
Yeah. Let's hope in one of the lectures we will see that definitely. Because last time also our lecturers showed a lot. So bad granulation is blobby, sort of bluish discoloration to red. So it's not uniform. So that we expect these things when you describe the wound in your case. So moving on. So now you know all these things. You have to take a history examination, you have to describe and all that. So now what? So you have to diagnose the wound. So you know all that, you have described it and all that. So what type of a wound is it? Is it an ischemic wound? Is it a venous wound? Is it a pressure sore? Or is it osteomyelitis? Is it because of vasculitis? So with your history examination and your wound description, now you have to be able to say what kind of a wound this is. So all this will be discussed during the course. So again, in the assignment, this is what you have to do. And another point, this I don't think this probably is not discussed. The healability, say whether it's a healable or a maintenance. Say if you come across a palliative patient who might die in about a month, and he has a bed sore, quite granulated and all that. But it will take about 3 months to heal with best of care and offloading. So that's a maintenance. Because the surprise question is, we are not surprised if the patient dies in 1 month. So that we go into a paradigm of maintenance. We have to remove the odor, remove pain, keep the patient as pain-free as possible, reduce the burden of this particular wound until he or she has passed away. So the healability, whether this particular wound is, say, a foot wound, foot ulcer, a diabetic foot ulcer, poorly controlled diabetes, anemia, and all that, and there are some aspect of pressure as well, the foot pressure as well. So it's healable. The patient, you offload, correct all that, it's healable. And say at this particular point, whether it's healable. Another point, aspect to think about. Say you get a ischemic wound, dry gangrene, very painful and all that. Can you heal it now? Right now, can you put the patient on a so is your approach to heal the wound right now? Chop off all the necrotic tissue, manage the wound bed and heal it. That's the way. Come on, some answers. Anybody?
Can you repeat the question, please?
You get a ischemic wound in the foot with dry gangrene. And are you classifying it as a healable wound right now? Are you now, if you want to heal that wound, you have to chop off the dead tissue and give a lot of moisture. And if there's anything else needed, correct that as well and do it. Is it now in your clinic?
It's healable. That is, I think I'm still not clear with the question. Sorry.
Yeah. Okay. Anyway, I'll answer
If
that.
it is gangrene, it can't survive normal anymore. It can't. If it is a gangrene, there is no blood supply and it become died already. So
No, part of it has died. Patient's problem is a dead toe. Very painful.
We have to look whether there is any arterial occlusion by doing duplex investigations.
Yeah, that's what I'm saying. It's ischemic. You have diagnosed it as ischemic. In your examination, there are no pulses.
Then it's difficult.
No, my point is now it's not healable right now. It's healable once we have done the correction of the vasculature. Until then, it's a maintenance. You take away the pain, and you take to take away further wounding, to prevent further wounding, and you don't do anything else. I mean, if it's dry gangrene, don't touch it, don't cut it, no moisture. Just maintain the whatever is there. Just maintain it. Refer to the vascular surgeon. Get it done. Get the revascularization done. Then probably the vascular surgeon, if he's happy, he will chop off the dead tissue. Then you can manage the rest of the wound bed. Or else, if he sends to you, you chop it off, and continue with the wound care. That's the paradigm is healing. So we are doing maximum to heal. So at that point, whether it's healable, because can we do the
no?
Is there anything? So we need help. So that's what I wanted to discuss here. Healability. Okay. So again, now once we have diagnosed and we have come to say we have decided this is a healable wound, then again comes how to approach this wound. I'm not talking about the patient. Now, patient, we have a set of things and we have to correct all that. So that is different. Now, I'm talking about the wound bed. So wound bed, the approach is time. So this, I think Tushan will go into depth of this. So there are concepts. So we all go in evidence-based concepts. So this is what we are going to accept in you are going to learn during this month. So how to do tissue management, how to get from this wet gangrene to a clean wound. Then infection management, how to get rid of infection. That's an abscess. So how to maybe whether to drain it, whether to do give antibiotics or whatever. So those things. And moisture balance. It's a healable wound. The cause is accurate and corrected, blood supply adequate. All the patient-centered concerns are addressed. In the sense, if if he has anemia corrected, hyperproteinemia corrected, you have if there's any psychological, social, or any other issue, everything have been addressed, then moisture balance is the way to go. Wound care is 99% wound care is moisture balance, nothing else. You to manage moisture, just remember this. If there are more moisture, take it out. If there is less moisture, give it. Maintain the optimum moisture. That is the aim of wound care. Any question on this?
No.
So the next one is the epithelium. How to get the epithelium to advance. So from this totally open hollow thing to what you see on the other side. So you can use various methods, various, you can even suture. One or two sutures here and there to reduce the wound area, keep the epithelium close to each other, let it heal. Or you can use other methods. You can use a negative pressure vac or whatever. So get it filled, let the epithelium grow, support the epithelium with some moisture, all that. So the next thing is about, say, the dressings are about maybe 10% of wound care. So do you appreciate that? I mean, mainly people perceive that wound care is dressing changes. No? So only at the end of the discussion, we are coming to dressing selection. It's about 10%. There's so many things to do when you get a patient with a wound. So what are the types of dressings? Do we need antiseptics? Are we going to use non-adherents? There anything you need to add? So, and what's an ideal dressing? So that will be discussed during a whole lecture is there for that. And to decide on that, you have to just ask few questions. If there's what is the level of moisture in this food, whether it's more, less, or adequate. If there's infection, if you need to do any debridement, are you expecting to do a little bit of debridement as well or anything else? Any other function that you want out of this dressing? And when you're applying a dressing, there are certain layers of dressings. Primary dressing which goes into the wound and to secure that the secondary, then the tertiary dressing which will address certain other issues. So just have all this in mind. These will be discussed. And whether you need to offload. If it's in the foot or if it's in the back, if it's a palliative patient with a pressure ulcer, whether you need to offload and how to offload. And how to plan a review. Is it EOD as usual every other day, or are you going to do the proper way? When are you going to see this patient? It can be the decision you take can depend on the wound itself, the condition of the wound, or any other disease or any other problem the patient has. You get what I mean? So the other thing is antibiotics. As you all correctly said in the beginning, we don't need antibiotics for all the wounds. Antibiotics, if you use antibiotics routinely, that will only give rise to resistance. And I think the last antibiotic to come was linezolid. That also had some resistance later on. Mild sort of inhibition, mid-level of inhibition. So, the companies are not really producing these antibiotics because it's expensive, one, and now the paradigm is to make some money on non-communicable diseases rather than this, because communicable diseases are the era of communicable diseases are gone. So don't expect more antibiotics to come. If somebody is using antibiotics irrationally, basically we are asking for trouble for our children. So just remember that. And the other aspect to think about is wound prevention. This will also be discussed in this during this course. So prevention of bed sores and the ways to do it, the skin care, stomach care, comorbid control, hydration, nutrition, and prevention of foot wounds, foot care, footwear, and levels of prevention, prevention of rewounding. So those aspects. Your management, the management schedule must have preventive aspects as well. You must address the preventive aspects. So, for example, this the prevention of bed sores. And end of all this, you have to identify these red alerts. There are no distal pulse, refer. There are dry gangrene. Again, you have to go into the vascular free, reassess, and you have no pulse, refer. Wet gangrene again. You can do something about it, do it, or otherwise, for the nurses, actually, what we say is refer all this. Sepsis, you have to identify and understand the levels of sepsis, and you can manage that accordingly. If you need help, ask at that point. Referral is not a bad thing to do. There's pus, you have to drain it. Excessive bleeding, you have to manage. Mostly this comes in like palliative wounds, cancer wounds. There's excessive bleeding. You might have to ask for help. Maybe the patient needs the ligation of a vessel, say the carotid in mouth cancer. If the wound is spreading, then again you have to go back to basics, reassess, and if it's if you get the same solution, ask for help. If the other associated medical conditions are escalating, if you cannot manage them, ask for help. And if the wound is not progressing, say in about 2 weeks, if it's the same as you saw, that's why the photography is important. It's better if you can keep a photographic record. Then if there are no progression, go back to basics, reassess, or refer. So a little bit about research. We have actually spoke about this. So the easiest way is to tag along with major investigation. There are people who do a lot of research on wounds, biofilm and all that, say foot care and all that. Just tag along with them, follow their research, and just learn to read a little bit of technical jargon. Then you can go into your new research as well. And definitely do not learn from the drug rep. He, for your information, he had a marketing, he did a marketing degree or a diploma, not medicine. So always go on medicine, on the evidence. So how many of you all have learned from the drug rep what to put and what dressing to put in what for what wounds? Anybody?
Yeah, we are always educated by drug reps.
Yeah, so that's the thing. Yeah, so the drug rep has done a medical marketing degree, not medicine. So again, I don't want to ask all this again. So so thank you very much. That's the end of the talk today. So we are finishing a little early. I think we can entertain a little bit of questions. Any questions? Did I make any sense for talking about all this? Did I challenge
Absolutely.
your thinking pattern a little bit? No.
Yes.
So you think this is a worthwhile exercise?
Absolutely.
Something in the
Hi, everybody. I think Dr. Tusida Kahadu has given wound biology plus
Yes, sir.
overall. Can you hear me?
Yeah.
Yeah. He did wound biology plus overall management of just to introduce the overall management of wound. I think this is the time for question and answer from this session. This is over to you. You may be having a lot of questions. So then in the future, there are certain things you can clarify from this lecture. You can ask several questions or you can discuss with your experience. Over to you.
So really
Jessica?
appreciate, really appreciate the meeting chat. Somebody has said
Yeah.
it's an eye opener. Yeah, that's what I wanted to do. I mean, just wanted to challenge whatever you are practicing now, and just to introduce certain ways of thinking, just certain way of looking at a patient with a wound.
This then we have some more time. You
Yeah.
can explain the assignment. So then
Yeah.
next day also you can give some overview. I think it is better to give some overview of the assignment today too. Then
Actually you
it
can do
will
that.
be helpful for the next session also. Then ultimately they want to know what they have to do.
Yeah, sure.
Can you share that?
Yeah, just trying, madam. It's yeah, trying to find it. Yeah.
If you can.
No, yeah, it's okay. I got it.
Yeah. You have shared some other, your presentation. You have to remove that presentation.
Stop sharing.
You can first you have to remove your present presentation, then
Yeah,
you
that's what
can
I'm trying.
upload.
That's what I'm trying to do. So,
I don't know whether I can do that.
I think I got it. Yeah, wait. Yeah. No, some other report.
All right.
No.
Now we can see.
No,
Some
that,
other
that's
report.
not no, it's some other report.
Corrected.
Yeah.
Can you remove that? Then sometime I will be able to do that.
I think this is it. Yeah. No, that's the
All right.
again
Right.
the wrong one.
Yeah.
Wait, here. Okay.
This is the program lineup, right?
Yeah.
Assignment. Right.
Yeah. So
Assignment.
this is the first page. Basically, just copy this and just this is in Word format. Just copy this and fill in the blanks, because this is diploma, MSc, all those basically go like this. Very generic. So just fill in the blanks. So second page also use these sizing, say spacing and character sizes and all that. So numbering and all that, you can do it very formally. Headings in bold, subheadings in bold, italics and all that. So these are the topics. You can just get these topics, copy this, and otherwise just fill in the blanks in this. So just a quick proper introduction to the case, and you are learning wound biology. So the introduction to the case should involve, it should include description of the patient, history, examination, whatever is needed, the investigations indicated. Those are not, I mean, you don't have to do it if you don't have the facilities. Just mention these investigations. I would consider doing these investigations, and I would expect to see these things also. And then you go into say wound diagnosis and all that with wound biology. So to describe the wound biology, you will get the wound biology lecture next week. So apply that knowledge into your wound and describe what's happening in your wound. You can just follow the lecture and apply that. What's happening in your wound? Is that clear?
Yes.
Right?
Yeah, it's clear.
So try to describe in terms of wound biology what's happening in your wound. So again, wound bed preparation, what you did, what you got out of the lecture and what you did in your case. Time principle, you applied it and all that. So then the dressing selection. Follow the lecture, dressing selection, apply that knowledge. How you selected that particular dressing? What is the rationale? And how would what would you expect from it? And what are the layers of that dressing that you used and all that? So say the primary dressing is this, the second dressing is this, tertiary dressing is this. I would expect the primary dressing to do these things, tertiary dressing to probably offload and or to just give some compression and all that. So those things you have to describe. Why you did it, and how you did it and why you did it. And overall management of the patient. This if your case is such, the overall management can come after the introduction as well. This is just a example lineup. So outcome as of now, in the sense outcome as of when you are finishing the assignment. And what are the measures you took for wound prevention in this case? How did you look at it in a preventive eye? And then the discussion. What are the barriers and difficulties you encountered? The barriers and difficulties can be it can be in the wound, in the patient, or outside in your clinic, in your locale, or even the scenario in the political, even the political scenario, for example, in the country. So just the barriers and difficulties in a specific terms and broad terms as well, and a brief discussion of things like I mean, this is what I this is this kind of wound, say an ischemic wound. This is how I manage, and the world literature. We would love to see you citing some literature. This is what the world scenario is. This is the Sri Lankan scenario. This is how people have managed such wounds, and these are the case reports. So trials we encountered, and all that should come in the references. And recommendations, actually, recommendations can be very bold and hairy. You can recommend anything, even to remove the Sri Lankan president and put someone from the Aragal layer. That is also acceptable because that is your recommendation. So remember to use the jargon you learned in the lectures. That is very easy for us to follow through then. That's why we also try to use jargon. And real life pictures in all possible topics. The way you did it, while you are doing it, or so of course with the privacy of the patient. And if you are posting pics of the patient, just get a little bit of a signature as well. So that'll be good. So and the discussion must be targeted on your case, not anything else. You should discuss your case, how others saw it, how the world saw it, how the local experts saw it, and how you saw it. And basically, what you took out of it also should come into play in the discussion. This is what I learned. So, and the recommendations, as I said, can be very bold and hairy. So, are there any questions?
Tusita, can you please explain the majority of doctors who are joining with us? They are doing day-to-day practice.
Yeah.
Most of them they are meeting patients with wounds, but sometimes those who are not meeting this type of patients, what they can do, how they are going to do this exercise.
Yeah, if they can get some wounds from the, say, let's say from their own clinic, their surgical clinic or surgical ward, if they are willing to lend lend a patient, and you can ask some help from the surgeon or the registrar or somebody who's senior, or else if you have no access at all, say if you are working in the public health sector or in the ministry or administrative sector, whatever, I can send some scenarios and pictures so that you can develop your case on that.
Can we ask, are there any doctors like that? dear
Yes,
delegates, and
yeah, I would like to have Dr. Tusita, like, if you can send me
Yeah.
some pictures, yeah.
But
where are you working?
Razia, no?
Yeah, I'm
You
Razia.
can discuss your mother, no?
Exactly, but you are the one who's treating now. Okay, I should do that then.
Okay.
Okay, thank you.
Hi, can I have such patient as well?
Yeah. Yeah.
My
I can
registration
send
number
you.
is 610.
Okay, just send me a WhatsApp message, and just your. I mean, I have quite a number of cases. I can give you if you say if you are comfortable with venous wounds, I can send you a venous thing. Or otherwise, I can just select something and send.
Okay, whatever you prefer, or
Yeah,
a
just
venous
send.
also would be
Yeah,
great. Yeah,
send me a WhatsApp message. I'll send you something.
sure. Thank you very much.
Any other questions? One more questions I want to ask. All of you are in the WhatsApp group now.
What time we
Hello,
can start the exercise, madam? That
I
from
can't hear
beginning of
you.
the PowerPoint. What time we
I
can
can't hear
start that
you.
exercise? What time
Tusita,
we
what
can
did
start
you?
it?
You mean the assignment?
Yeah.
Yeah. Now try to figure out what you are going to do. A case.
Mhm.
Then you can start writing probably from next week's. Now listen to Doctor. Now take the introduction part from this lecture, the patient factors and the wound description and all that from this lecture, and wound biology from probably from next week. I think you should start slowly writing. And then chapter by chapter you finish. Now we have actually not put a word limit or certain page limits and all, page number and all that. But I think you should write, I think, adequate number of pages on this. And there can be annexures, and there must be references. And whatever you are, if you are taking, say, graphs or any other pictures from any other publication, you should put the source. Any picture or whatever, you should have the source. So that's how to write it. So you can, your own photographs, you can say source is author. So any adjunct documents are entertained.
We have to present one case or several cases.
No, just one case. You don't have to present. You can. I mean, you
So
can.
then yeah. The assessment.
Yeah, one case.
Assignment,
Assignment is around one case, not to complicate things. And I mean, if you want to say discuss the case in the class, that is also okay. We can find some time, I guess. If you want another session to present and discuss and all that, we can probably we can look into that with the availability of the resource people. Or if we are really ready, really geared, I can invite probably Professor Mandika, Professor Kasim, and all those high rankers, and scrutinize your case. You can present about maybe 5 cases, and they can have a go at you. That will be an additional session.
Any other questions?
So some are apparently not in the WhatsApp group.
Yeah, I note down your numbers. And Chitra, you are there, no?
Yes, madam.
Yes, we can note down these numbers and we can add them. You have given your number, no? Yes. Don't worry, you will be added and everything is in the your all the messages we are sending to your email too.
So
Any other questions?
there are no other questions. Can we call it a day?
Yeah. So actually, thank you very much for your active participation, and also then every day, day by day, you will be improving. I hope this course will help for your patients as well as maybe your relations or friends. You can practice this knowledge wherever you are meeting patients. This will be really helpful. And also this will really improve the quality of patients in our country. So thank you so much. So then we will upload the presentation into your WhatsApp group after adding all these numbers. Then it will be available 7 days after the uploading. Then we will remove it. So anytime you can use the WhatsApp group asking questions. So then faculty members, they will answer your questions. And Dr. Tusita will explain the, already he explained the assignment, and also he will, every day he will be presenting if you have any problem with the assignment. So thank you so much. So we can wind up the session. Have a nice weekend. Good night. Anything else you want to say, Hitira or Dr. Tusita?
No, that's it, madam. Thank you very much, Madam President, and Chitira for your hard administrative work. And good night, all. Chitira, do you want to add anything?
No, I'll add the remaining numbers to the WhatsApp group if and again I'll say sorry if I couldn't add your first add your numbers initially. So anyway, I'll add the remaining numbers. Okay.
Yeah, and Madam, Chitra is also a participant. No? He has to
Yes.
follow the.
No, that doesn't matter.
Yeah.
I wrote down numbers.
Yeah.
Just before wind up, I need a few more numbers to note
And you
down.
have to make sure that he's submitting his assignment. No.
Yes, yes. Right, right. Tusita, Chitra, if you can, some of them have gone, so then we will let them, everybody.
Okay.
Okay,
Right,
thank you very
okay.
much, madam. Okay.
Thank you.